the simplest approach starts with basics, which is why we're here today. We want to learn some of those basics. And as nurses, we have all given ketamine at one point or another. And so I'm very excited for this lecture and to see how Dr. Maysa has incorporated ketamine into her studies. So I will pass it on to her.
Thank you, Lucy. Let me make sure that everything's working here. Okay, I'm going to share my screen for this lecture, but yes, I'm really excited to be here to talk about what is my my focus in my practice now. As you can see, I've done a lot of things over the years, but as I'm forming more into myself and what's most in alignment for me, working with ketamine has brought me exceptional amounts of joy and sense of real worth in this lifetime to help other people amplify their consciousness. And so I'm really excited to talk about what is actually the only legal mind manifesting therapy to one great extent or another. There are still some like more secretive or unknown plants that could be utilized. But in terms of like mainstream medicine, we have this one tool in which we're kind of seeing what's a Wild West right now with the advent of many people doing this type of medicine and many ketamine clinics popping up. I thought it was important for y'all to know, both as healthcare practitioners and potential psychonauts yourself, about this form of medicine. And so that you have a sense for when you are administering it, how you can help a patient and maybe avoid some side effects, maybe prepare them to have an even deeper and more meaningful experience than you will maybe perhaps when giving them propofol or maybe even propranolol or just the other various medicines that you're pushing here. So great opportunity to learn more. So I'd like to share my content, but it says only the host can share in this meeting. So perhaps Lucy can give me the right of way with that. And screen sharing. Can y'all see this?
Yes.
You can see it says ketamine therapy, the new frontier.
Yeah.
Okay, great. This is the first time I'm doing it on an iPad. This is my new personal computer, essentially. Okay, so yeah, as I mentioned, ketamine therapies are kind of the new frontier. The field in ketamine therapy has been around for about 50 years or so, relatively recent drug, patented in the 60s. So we're excited to talk a little more about how that field is looking so far. We'll talk about the history, the pharmacology, and the current clinical practice and applications that I mean, as well as some, patient encounters, the things that I'm seeing when working with this medicine in my practice, and then some references and time for Q&A at the end. So the history, ketamine, its chemical name is ketamine hydrochloride. It was invented by a chemist in 1962. And it was part of Park Davis's pharmaceutical company's quest to find an ideal anesthetic. So they actually developed its own form of a chemical anesthetic, the aryl cyclohexamines, which we'll talk about in the next slide. And so they had gone through discovering PCP and then another less desirable version of PCP, and then thirdly ketamine, and that process has been going on since about, I believe, the 40s. So in this quest to find a desirable anesthetic, ketamine, first known as Ketalar when it was a patented drug, came out onto the market, and it was designed as a human and animal anesthetic. So when it was studied initially, the subjects were inmates at the Jackson prison in Michigan. And an American physician, Dr. Edward Domino, was the one who conducted that study. And so they gave it to these prisoners. And he came home and talked to his wife about the effects. And they were trying to find a way to coin the term for what it does without making it sound like a drug of abuse or something wholly negative, or trying to find an objective way to describe it so that this drug could be marketed, since he was working with a pharmaceutical company to better understand this product. So his wife actually coined the term of a dissociative anesthetic, and that is a great way to describe what ketamine does. Anesthetics is something that puts us at anesthesia, so it's going to maybe create a difficulty of remembering, but most importantly a release from any sensation of pain. And in this case, this anesthetic response of ketamine dissociates the mind from the body. So very interesting when you come to think about what is a psychedelic or out of body or a mental experience where your mind is manifesting. And in this case, it's separated from the body via this dissociative anesthetic effect. So we saw that ketamine was very popularly used in World War II. They coined it the buddy drug because of its ease of administration. It was given in the battlefield, and your buddy could just give you a shot and you would be relieved from your pain, you'd be relieved from your anxiety, you'd be able to be moved or mobilized off the battlefield. And so for that reason, it was utilized as the prominent drug for evacuations from the battlefield in the Vietnam War. And they cite that, and ketamine specifically, to be very important in reducing the mortality rates between those two wars and for veterans that were injured in combat. So very interesting that it was being so well utilized at that time. So we've known about the benefits for quite some while. The first publication about the mental psycho analytic and more what we're seeing now with the therapies, the first publication of that nature was by a pioneer analyst from Mexico, Salvador Roque, and he started working with ketamine in the 60s. And his approach warrants its own slide. I mean, this textbook that I gathered much of my research from for this talk gives like a whole chapter in dedication to Salvador Roque. He was a very mixed viewed figure, it seems, because he had a very political relationship with Mexico, and he was actually given like this special permission to use this drug, and wasn't really he was basically given free reign. And in return, it was said that he was helpful in using it for allowing the government to have some insight into how to use it for interrogation purposes and various other things. So I think he was very like a politically charged figure, but they do a lot of interesting reports of what it was like for him in Mexico to have been giving this medicine. And the way that he did it was unusual for us today in like a very clinically minded society, because he was mixing it with a lot of other things. Roque would do these sessions that were like 24 hours long with a few hours of interspersed sleep, where hundreds of people would get in a room who were his patients, get to know one another a little bit. And then they would put this really stimulating video footage and music, and kind of like we're trying to like jar the patients into a certain experience. And I mean, it sounded like some of it was probably pretty brutal, in that you're just being really overstimulated. And in one case, there was a case report where a patient was like, I know I'm hallucinating, but I see my father approaching me and I just want to tell him that I'm sorry. And it actually was his father. Like Roque had made this like grand plan to bring the father into the therapy. And so he would use ketamine at the very end of a process of many other psychedelics, mushrooms, LSD, datura, which is a very powerful hallucinogen. And he used the ketamine as a way to integrate the experience at the end, to give them some relief from the mental chaos they had been through. Kind of like if you were going to craft an experience of a hero's journey, which, a lot of people who have done LSD will describe an LSD experience as exactly that, like a hero's journey. You have to overmount, or any psychedelic really, you have to overcome or overmount a challenge or some kind of, demon created from yourself or from an event in the past. And so he would really make sure that patients were getting that as part of their facilitation. And in the end, there would be integration groups and small breakout groups. So kind of like very interesting. So these folks from the Maryland Research Center, Psychiatric Research Center, MPRC, were also doing research with psychedelics, LSD, LSD plus IV Ritalin, which apparently helps the LSD be a little more easy to handle when you hit those roadblocks in your hero's journey. And they started to get invitations from Roque to come to Mexico, see what he was doing, be a part of it. There's a lot of very, famous people who came out of MPRC to do this research. And one of them is actually a mentor of mine, Bill Richards. So he was a part of that group. And the amazing thing is, you have these accounts of like Roque's freedom to blend and find an art in this medicine. And the research center folks were like, we're so tied to our protocols. So you'll see that there were very differing approaches. And now it seems like in the Western world, we have moved more towards really standardizing and saying, well, I don't really know what the effect of the ketamine was if I'm mixing with all this stuff. And I just want to prove the efficacy of the ketamine versus one thing or another. But you can see that even in our own past using electroconvulsive therapy, we don't know, was it the ECT or was it actually that ketamine was used as the anesthetic for ECT? Interesting question, right? ECT is considered like the granddaddy gun for people who don't respond and have really treatment resistant depression or really severe psychosis and various other issues. We think, okay, ECT, at least there's that. But interestingly enough, ketamine was used as the anesthetic for that, because when you are providing convulsive shock therapy, you don't want the patient's body to be writhing around. You don't want them to experience pain. You don't want them to have any memory of the event. So ketamine was one of the anesthetics used in the cocktail to help put people under for ECT. So, who's to say what the efficacy was due to? But interestingly enough, I think ketamine is kind of like a form of ECT in a way, because the way I like to describe it is putting the brain offline and allowing it to, separate from the body in a way. So it gives you what I like to call it like a bit of mental rest, and to just be experiencing as a state of consciousness and a state of oneness, an expansive state. So lastly, we'll get to the current day use, and there's so many uses. So that has its own slides up ahead. More into the pharmacology, I just think it's so interesting that, we don't really know what exactly is happening, but this is the best that we can come up with at this time. As I mentioned, the aryl cyclohexamines were a series of chemical compounds developed as anesthetics by the pharmaceutical company Parke-Davis. And they were on this quest to find the perfect anesthetic. And unlike other anesthetics, with the exception of nitrous oxide, which women actually get during labor and delivery in Europe and some parts of America, this anesthetic does not extinguish the consciousness. In fact, it dissociates the mind and body, and maybe you could say even expands the consciousness, which I would argue that it does. And this quest to develop these anesthetics started with PCP, also known as angel dust, but phencyclophenidine, in 1926. And this, was used fine in the chemical world, in the medical world, but then its street use got it a bad rap. And because a lot of times the addictive potential of it, I think, overwhelmed the consumer, and they would go on what was called binges of 2 or 3 days of using PCP. And you hear about, oh man, PCP made that person crazy, and they would like try and lift a car, or they'd get this intense energy. And so of course, with varying doses, you see varying responses, but in general, it was widely used as a liquid form in which people could dip their, cannabis cigarettes or various other cigarettes in and smoke, or be used as a powder or a dust. So they then tried to create a less palatable version of PCP so that it wouldn't be as useful for abuse. That's edecyclidine, and that had some side effects. And unlike PCP, you don't see edecyclidine anymore, and you don't even see it in the research world really. But PCP you do, and still it's like a research compound. I think it's a Schedule 1 compound, and then that progressed into ketamine in 1966. So that's the one where they basically said, oh, we found the perfect one. Let's stop here. Since then, it's been created as a generic. It started as Ketalar. And the way that PCP was marketed was as a drug called Serenil for its serenity-inducing experience. So I thought that was kind of a funny name, like, you hear Soma and various other drug names trying to encapsulate the experience within the name of the drug. So Serenil. The actions of these compounds, the aryl cyclohexamines, across the board, they're NMDA receptor antagonists. So the NMDA receptor is heavily found in the cortex, various other parts of the brain, and it prevents, by antagonizing or inhibiting the action on the NMDA receptor, glutamate does not act on it. So we're preventing the receptor from being activated by glutamate. So you have all this extra glutamate running around in the brain that isn't adhering to the receptor and causing the glutamate-induced changes. And glutamate, we know, is an excitatory neurotransmitter. So in a way, like, we're inhibiting that excitatory action. Mu opioid receptors are also impacted, and we believe that's a lot of what the pain relieving benefit of ketamine is. It's an agonist of that receptor. That receptor is also implicated in alcohol abuse. So very interesting that ketamine has been used effectively to inhibit alcohol abuse and various other abusive substances, including heroin, and help people get into a state of remission from substance abuse. The dopamine reuptake inhibition means that more dopamine's around, and that can have a hallucinogenic effect. The N-acetylcholine receptor antagonism has a lot of implications in the sympathetic and parasympathetic nervous systems. And then you have the D2 dopamine receptor agonism. So again, stimulating the action of dopamine. The pharmacology of ketamine specifically, we see it naturally occurring in the synthesis as a racemic mixture of R and S enantiomers. And if you remember from chemistry, the R was the right hand and the S was the left hand, or the sinister, because they considered left-handed folks or the left to be something sinister back in the day. It had that term and was called S enantiomer. So you'll see that the S-ketamine that's being produced by Johnson & Johnson now is a nasal spray, the first, mass-produced type of like ketamine being used for therapy purposes and for depression, specifically treatment-resistant depression, is not a racemic mixture. It's just the S-enantiomer. And internal studies within Johnson & Johnson showed that actually the effect of the S-ketamine is less effective than the racemic mixture. The advantage to doing just S-ketamine is that that's a new pharmacologic synthesis in a way. That's a new drug, and we can then say it has a new patent on it. So there's a lot of money to be made for isolating that one, because the generic ketamine would not be making them so much money if it were in a nasal spray. So, I expect that probably in 40 years, they're going to say, hey, now we want to do the R enantiomer, and we'll have ketamine or some other version of that. And then they can, milk that for 40 years or whatever, until it becomes generic again. So here I'm just saying that the racemic mixture is thought to be more effective or better than just one isolate. And so a famous example of racemic mixtures is thalidomide, the drug for morning sickness in women, where they actually gave, and I believe they gave the racemic mixture, and one of the enantiomers was actually highly toxic. But if you gave the other one, you wouldn't have the highly toxic effect of birth deformities. And these children were, coined the term flipper babies because of the severity of the limbs that were shortened. And so an example of how important the chemistry is, and that you do get different effects from isolating one enantiomer over another versus having a racemic mixture. So the other thing about S-ketamine I should note, this is also known as Spravato, is although it's covered by insurance in most cases, you have to be on an antidepressant concurrently to qualify for treatment. So you're going to be consuming a couple of pharmaceutical drugs, and the fact that it's really just being prescribed as a treatment indefinitely, like you're coming back every week for this. You have to stay in the office for 3 hours. I think it's really limiting. I don't use it in my practice for those reasons. I also don't work with insurance companies because I've just seen too much criminal and fraudulent activity from them, both personally and how they have treated my own health and the health of my patients who, in some cases have applied to get reimbursement for our completely legitimate medical meetings. And then the insurance company comes back to state, hey, we made a mistake. You owe us that $1,200 back or whatnot. So I just don't entangle myself with that. And that's just another reason that I don't really use the Johnson & Johnson product.
Dr. Maysa, David has a quick question
Yeah.
before we move on.
Sure. Yeah.
So the ketamine that we use in the hospital is just which version is that one?
It's going to be the racemic mixture, the Ketelar, the generic, the cheap. Yeah, exactly. So you're going to get R and S. So yeah, you have an opportunity to kind of like help maybe mentally prepare somebody to have a potentially very mind altering and life-changing experience, even in one dose with the antidepressant effects we're seeing from the racemic mixture. So yeah, that's the kind you'll be using, and only in that nasal spray form, of which there are only 2 doses. There's a lower dose and a slightly higher dose. That higher dose is 84 milligrams, and 84 milligrams, if you look at the bioavailability of ketamine by the nose versus the vein, which what you're probably doing is doing a vein, let's say the vein, we call that 100% bioavailable. The intranasal is 25% bioavailable. So when your highest dose of ketamine that you can get is 84 milligrams by this Johnson & Johnson route, divide that by 4, okay? So you're getting, you're getting 21 milligrams by your nose, which, as you'll see in my following slides, is so little. I wouldn't expect it it's not going to give someone that major transpersonal ego dissociative state that you could actually potentially get a cure out of them. So it's like giving them just enough to make things better, and I mean, when you think about the intentions of these organizations, like the bottom line is their business is to make money. So that's a pretty good strategy. You're not really ever going to get someone too well, but they might get a little bit of relief, and they have to be on the antidepressant also. So, when you're giving it IV, you're getting 100% bioavailability, and you're giving it IM, you get really close. You get 93%. So just think about when the dose that you're giving a patient to take them down, like a chemical takedown in the ER. I've had some paramedics give a patient 300 milligrams, that's 300 milligrams IM. You're almost getting all of that in, and that will take them out. That's going to take them to one of these transpersonal ego dissolving states. Usually around 150 to 200 milligrams will most definitely do it. And we just don't see it a lot in the lower doses. So when you're thinking about how do you equate what you're giving IV versus these therapies, just knowing that bioavailability is 25% with intranasal, 93 with IM, and 100 with IV, you can kind of make sense for like how much of a dose someone's getting. And just to note on that, in case you're curious, the intranasal route has so much variability. I mean, as you can imagine, the swelling of your nasal mucosa, just how much actually gets up in there. Then you have the side effects of the taste and the maybe like a dripping feeling or whatever with intranasal drugs that you get, like any type of nasal spray. And used recreationally, there's a lot of variability for like how much someone might take and experience. So you just don't have a lot of control. That's why they did make a metered nasal spray, and they are only giving, 1 of 2 doses. It's not, there's not really much more variability than that in their delivery model. So, but yet still, even if you're delivering 84 milligrams, you've got a patient with a lot of nasal congestion or less mucosa, or they've had some kind of trauma to the mucosa, they may not really be benefiting from 84 milligrams or really much, even 25% of that. So I just don't think intranasal is a very good route. And I see it more as like a money grab, because we could easily be treating people with intramuscular, but it's not as lucrative for a pharmaceutical company as that medicine's generic now. Yeah.
Thank you.
Yeah, no problem. So the effects by the transport systems are interesting because, we're trying to understand how does this work and what's it actually doing. And we see that there's a lot of different routes of effect in these transport systems. So we think that the dissociative effect is primarily the action on inhibiting the NMDA receptor. And similarly, that there's a hallucinogenic effect when you inhibit NMDA and dopamine, and the sigma effect that you're having. I didn't really talk much about the sigma receptors, but they're also involved in the anxiolytic benefits of ketamine. And so is the effect on the D2 receptor and the mu receptor. And then the anticonvulsant properties and neuroprotectant properties are attributed to the NMDA and that extra glutamate running around. So what's really interesting is in teratomas, that was the first time I saw ketamine used as a medical student. I was working with a neurologist, and we had a patient who was in epileptic state. She had never had seizures before, but all of a sudden was just seizing just endlessly, and her brain was essentially overheating, and all that seizure activity could have caused permanent brain damage. And what they did was give her a ketamine drip, and so she stopped convulsing. They were able to figure out that very unusual, but I think it's common to teratomas. The teratoma can create NMDA receptor activation. So that teratoma, if we remember what that is like the formation of all these different fetal tissues as a tumor. Those can produce excess activation of NMDA receptors. And so by blocking that, they were able to stop her from seizing uncontrollably, protect her brain, and then remove the teratoma, and the seizures thus were inhibited. So I thought that was really fascinating. But in general, even if you're not seizing convulsively or having epileptic events, there's still a neuroprotective benefit via this NMDA receptor inhibition. We see that the analgesic effect of ketamine is mainly attributed to the mu receptor activation. The euphoria, as you can imagine, is effect of dopamine, is having more dopamine around and blocking some of the various ways it's transported, and the stimulant effect similarly. And lastly, the antidepressant. I mean, I think it's probably attributable to a lot of things, not just the dopamine, probably a lot of mu receptor activity and maybe even NMDA and acetylcholine. But we do see an instant antidepressant effect with these medicines. So now, what are the implications of these effects in our own neurochemistries? Well, having elevated dopamine levels is attributing to a lot of hallucinogenic effects, and the serotonin and GABA aren't really changing so much, so we don't think it's that. There has been ceruloplasmin activity increase noted, and that actually causes a conversion of monoamines into adrenochromes. And if you've read any Hunter S. Thompson, he talks about adrenochrome, but in that book, they get pretty crazy. And so they're hallucinating, and much of the book and much of probably his life was a lot of hallucination and a lot of out of body or very interesting psychedelic experiences. So when I think of adrenochromes, I definitely think of that book. And I can imagine that having more of that in our system would probably induce more of those Hunter S. Thompson states. Beta endorphins levels being increased is going to help with depression as well. And then we see a monoamine oxidase inhibition. MAOA and MAOB activity being decreased means there's more monoamine oxidases running around, and that contributes to hallucinogenic activity. As you may know, ayahuasca is an admixture of DMT and an MAOI. So the MAOI allows the DMT to persist in the body without being broken down. By having an MAO inhibitor on board, it will last, that DMT effect will last much longer when ingested. So similarly, like you can see how these MAOs, these monoamine oxidases, are important in creating hallucinogenic effects, and how by inhibiting their breakdown, we have more of them present to create more profound experiences. Then in terms of brainwave activity, we're seeing increased delta and theta activities. And the theta, I misspelled that on the slide, that should say theta. It's 3 to 4 times more theta activity in all of the cerebral cortex, which is responsible for processing, the cognitive mind. So really kind of amazing there. Theta brainwave states have been associated with deep states of healing, creativity, relaxed states, like our highest self kind of states. And so it's very fitting that this medication would be increasing those states. Glutamatergic changes are also associated with visionary experiences. And, I consider that a more accurate way of describing what a hallucination might be, but just having a visualization of something that isn't there, as well as ego dissolution, which, as we'll see in subsequent slides, is something you can pretty calculably get to with the right dose. Limbic system and cortical system interactions are worth noting. These NMDA receptors are mostly in the cortex, which, as I said, is cognitive mind processing, and in the hippocampus, which is involved in the process of integrating and transmitting incoming signals. And so when you block the incoming signals and the integration of that into the cognitive mind, you could imagine how this state you would be in would be free from sensory modalities or free from a lot of stimulation, because you're blocking the transmission of what that input is then to the rational mind to understand it and be appreciative of it and say, hey, I can appreciate that I'm breathing, or I can appreciate that I'm sensing something. And so it's very interesting that you could cut that signal off and really just dissociate those incoming modalities from your presence. And so all that being said, this is a way to connect the conscious and unconscious minds. And as we know with psychedelic therapies, to mind manifest and bring forth maybe those deeper layers and experience those deeper states of what would be, comparable to enlightenment. So in creating these aryl cyclohexamines, the quest for the ideal anesthetic was there driving the motivation of these companies. And so ketamine has all these properties. It was basically the ideal anesthetic in their eyes, and still is. So what are those effects? Well, we want something effective at inducing the anesthesia, the relief from pain. We wanted minimal cardiovascular effects, minimal respiratory effects. We see ketamine doesn't decrease the respiratory drive, with the exception of very, very high doses. We wanted an ability to titrate, which we most definitely are able to do that with this drug. Rapid onset of action, within minutes, both IV more quickly than IM, but IM 3 to 4 minutes. So even quite good for that. Predictable duration of effect, which we really do get. I have patients who are like on the dot, come out of their session within, start moving their bodies in a certain amount of time, usually 45 minutes. A short elimination half-life, which we see is about a couple of hours with ketamine. Anxiolytic at subanesthetic doses, which we certainly see in the research, and analgesic and subanesthetic doses as well. Solubility in water, stability in solution, absence of pain on injection. I get the occasional complaint of some burning, but for the most part, IVs, IV and IM both very comfortable, and the absence of post-injection irritation. So a lot of things to consider when you're choosing an anesthetic. And, I even asked my surgeon when I had my back surgery, I was like, can you please use ketamine? And, or the anesthesiologist, had a conversation with him, and he didn't even, it was like, I do what I do, honey, without saying those words. It was like, he wasn't even interested in having the conversation, but I was sitting there being like, I'd really prefer ketamine to propofol for these reasons and this and that. And the next thing I know, I'm asleep and awake and post-operative care. So I think it's like, as great as an anesthetic as it is, for whatever reason, you see some folks who just really don't don't really use it as much. And I think there is actually a push now we're seeing to really kind of like start using ketamine more in the surgical suites, not just for, ER takedowns and procedural sedation or conscious sedation. And I think I really love about it a lot, to speak to my own experience, and working in intensive care units, is I never stuck ketamine drop a patient's blood pressure like propofol. So I was really just, I would be kind of like hesitant for a patient in the ICU with septic shock to be on propofol. I would just always be advocating, like, can we use ketamine instead? Can we just start that in the ER? And so, I much preferred putting patients on ketamine drips to maintain their anesthesia and keep them on a respirator instead of propofol for even that reason alone. So it's kind of all that in a bag of chips. We've got a great safety profile, thousands of studies documenting that. We need little to no monitoring, especially when it comes to using it in a psychedelic clinic setting. It's cheap, easy to administer, easy to store. It doesn't need to be stored in a cold space or any particular, way. It's hemodynamically very stable for patients to take it. It can increase intracranial pressure a little bit, so we do screen for that. There's no hyperalgesia like with opioids, where if you give enough for a certain amount, you need to keep up titrating them. So although you can develop a little bit of ketamine tolerance, we're not seeing it cause excess pain or an increased sensation of pain like you see with the opioid family. We have a broad range of clinical applications for this medicine. The quick onset, the lack of inducing mania, you can still use it in patients who have a history of mania. Which, mushrooms might not be a great choice for a patient like that, because that can, propagate and encourage the mania. And it's an anesthetic of choice in those austere environments where, let's say, a country doesn't have a lot of infrastructure or a lot of resources, a lot of money. They could very easily put someone down for surgery with ketamine with repeated intramuscular injections. They may not have the money to monitor with EKGs and various other high-tech equipment. Ketamine would be an appropriate choice in that environment. I had a colleague who would use it in the field. He was an ER doc. He would be actually using it to put a patient into a state of anesthesia for in the field amputations in a very bad post. I think this was actually in Haiti after a lot of hurricanes, and you can use it in those environments very safely. So when I say austere, we can think of it as maybe in the developing world or places that are a little more remote to medical care. And for that reason, the WHO put it on the list of essential medicines, as well as for all the other reasons mentioned. And that was a list created in 2003. So we've known for quite some time now that it's a great medicine. Of course, with everything, there's a shadow side. And I love that in society now, we're like really looking at our shadows. It's become like a popular term to do shadow work, to look at what, it's never all one way or all the light. So without the darkness, there isn't the light. So what can we say for ketamine? The shadow side is that in very, very high doses with heavy recreational use of, grams per day, maybe 1 to 2 grams, this is usually intranasal. We've seen hemorrhagic cystitis and other urinary toxicities affecting the kidney, the bladder, ureters. So this is something just to be aware of. Someone heavily using it recreationally, that's the kind of environment in which we see the abuse occur. It's when it's a recreational use, but we don't see that in the clinic. Even with the sublingual troches, I think, with good monitoring and good integration and checking in on your patients, I think it's safe to send patients home with those medicines of the sublingual form of ketamine. But we do worry about folks who are using it kind of more as a street drug. And we're not really sure if it's being cut with anything that could be contributing. But in general, that's when we're seeing people become addicted. And I think one exception is, the very famous case of John C. Lilly, a physician, neuroscientist, analyst, and psychonaut who, there's stories of him being at Esalen, which is a very famous place in San Francisco designed to, bring people in for lectures and bring a lot of like intellectual conversations up and have opportunities for workshops and stuff. And he was reported to have like never left his van for the whole conference because he was so busy just injecting IM ketamine into his glute for to be out of his body, out of himself. And so with any type of addiction, we wonder, what's the underlying reason? What's that person trying to fill with within their life by use of this substance or food or, you know, shopping addictions or pornography addictions. So, you know, I suspect that, you know, he was troubled in a way, and this became his preferred drug of choice. And so it's, I think for the most part though, I think it's a very safe medication to be giving in a clinical environment. And this is more seen with recreational users. So then there's emergence phenomenon, which has been cited in the literature. What that was at the beginning of ketamine coming to the market, they were noticing people coming out of a ketamine-induced anesthetic state. And in that process, people would have like a violent reaction, maybe writhing around or, you know, being distraught or saying things are not making a whole lot of sense. And I think that's not uncommon with most anesthesia. They think it might have been around 12%. And what I would attribute this to is that that person was never properly prepared for what they were going to experience. And so where this comes into play in your work may be that when you know you're going to be administering ketamine, you prepare the patient and you tell them, okay, we're going to go into this state. It's a dreamlike state. You're going to be separated from your body. You're going to be in a state of expansion. So just know you're going to come back home to your body. And while we're going there, let's do that in a place that feels good for you. Can you think of where that happy, special place would be for you? What does that look like? Okay, it's the ocean. Okay, great. Just as I'm injecting the medication, take some deep breaths and visualize yourself at the ocean. Okay, you can hear the waves. You just kind of like set the stage is what we call that. And we do that in emergency medicine when we're giving it to children, when we're doing reductions of fractures, or just, you know, really to anyone that we can set the stage with. I think that's important. And, you know, I actually even saw an EMS group give ketamine to a friend of mine who was having a really difficult time. She was having a breakdown. It was related to COVID, I think other things going on, and the EMS came to get her because nothing we were doing was really able to help keep her safe. And I was really impressed that they were using ketamine there. And I asked them, would you be willing to set the stage with her? Because I think she's really terrified right now, and she's not acting like herself. And they're like, we will certainly do that. We will do our best. So I do think that, you know, that kind of acknowledgement, this is a different type of anesthetic, and we need to treat this in a special way to avoid the possibility of emergence or having any negative side effect, I think is worth just having conversations about in the field with our colleagues. And I'll give one last example of this. This is a case that my father-in-law told me, is that there was an anesthesiologist who went on vacation and came back, and they had switched his box of medications up, and he ends up giving the patient ketamine when he had meant to give something else. And so the husband comes out of the ketamine state, has this emergence reaction, and the wife's sitting there watching it, distressed, not knowing what to do or how to do. And so then they sue, and this hospital and the anesthesiologist try and get them to settle. And it would have been a great settlement, probably like 50 grand or so, or something of that nature. And then they said, no, we don't want to settle. The judge decides that they're worth, their emotional pain was worth $5,000. So the moral of that story is always settle and don't go to trial. So
I used ketamine in procedural sedation in the emergency department for reducing fractures, et cetera.
Mhm.
And I noticed that in like older patients, i.e. teenagers rather than younger kids, nausea and vomiting on emergence was much more common. And so we would routinely give Zofran with our ketamine. Is that something that you've experienced in your practice?
Yeah, you know, I haven't with the IM doses I'm using in my clinic currently, but we're about to start doing IV drips. And all the advice I'm getting around the board is pre-treat with Zofran for IV. And although it is a QT prolonger, and you just have to be aware that you can give too much Zofran, and I've seen it cause cardiac arrest in somebody, I think unless they have known QT prolongation with a 4 milligram dose, you're probably safe just giving it. And like you said, to prevent the nausea vomiting. Yeah, I think we see that in like around, like in the literature, I think it's around 10%. I'm not 100% sure, but it's not exceptionally high. And that's with probably around 100 milligrams IV. And that's kind of a standard IV drip dose, is 100 milligrams IV over 40 minutes to an hour. I'm curious if you'd be willing to comment on the doses that the kids were getting that caused that and the route of administration.
Yeah, ours, it was IV, and we would typically use 1 to 2 milligrams per kilo. The case that I'm thinking of in particular was definitely 2 milligrams per kilo and administered twice. It was a deep knee lac repair, and I was a little troubled by their limited use of local anesthetic, and a resident was doing it, and so it was taking longer. So we just kind of kept giving more. And this poor teenage girl, who was probably naive to a lot of things, she probably even hadn't even like had an alcoholic drink in her life, was like violently ill, and then and quite emotionally, like very tearful coming out of it. Like, I mean, it wasn't the ideal situation for sure. But I do just remember us giving it, like I said, the 1 dose of Zofran routinely. Most of my experience with ketamine in that situation has been positive and entertaining, even with some of the kids, you know, and the stuff they would talk about coming out of it. Parents in the room. But I just felt really bad for this one teenage girl, because like I said, given like pretty much max dose, and things had taken longer, and it was just not a pleasant experience for her.
Yeah, you know, it totally makes sense. I think a lot of it is that just, you know, opening your eyes, it can be very, you can get some nystagmus, and the actual physical vision can cause the nausea in and of itself. So, you know, maybe you can encourage them to kind of just keep their eyes closed, do deep breathing. Obviously, you're administering the Zofran or the perchlorperazine or whatever else you're using in conjunction. And do you know if the stage was set with her? From, I'm hearing the emotional, tearful side of things. Do you know if that was addressed, or not really?
I don't know if it was. I do know that we had a like projector on the wall that would it was projecting through what looked like a colorful kind of mixture of oil and water that would turn. So it was almost like a kaleidoscope, or kind of organic kaleidoscope that the kids yeah. So that was
something like making
a
trippy. That's kind of like what my treatment room looks like. Actually, we have a very dark room with a projector of like a nebula and these laser stars, and just like really nice mood lighting, because that can really help someone. Just, you know, if the room is bright too, that can be kind of troubling on, I think, the inner ear visual system, that's going to contribute to the nausea, vomiting as well. But yeah, that's cool. They had a little something for them to look at if they that's interesting and thoughtful.
Though I think she was quite nervous there. She was from a very Orthodox family, and so I think, you know, just the fact that she was in an emergency room having a procedure was very out of her element to begin with. And so so I have a feeling that contributed.
Yeah, that's a great opportunity when you know you have a psychedelic or substance naive patient who's only been in an ordinary state of consciousness all their life, and you're going to put them in this non-ordinary state of consciousness, is to just really let them know, so that they have that extra help in navigating the new space, or just being open to it and being welcome to it. And I think that could be really helpful.
The lack was from a motor vehicle accident that they had just been in. So that was probably also not helpful, in that they just had this emotionally traumatic event of being in an accident. So maybe an opportunity to actually help her through that. But
well, I think, you know, what we're seeing is, regardless of whether you had the conversation with her, there is an antidepressant effect, and it could peak for her like 2 to 3 days after and last up to weeks. So I think giving her the ketamine, even though the stage wasn't prepared and she had these side effects, and there might have been some mild, like, you know, it can be traumatic in and of itself, but I like to think that hopefully the benefit outweighed the aspects of the negative there in that circumstance. And yes, you know, having all that happen at once, I'm sure in and of itself was really overwhelming for her. But
thank you for answering my question.
Oh, of course. There was another one too, right?
Yeah. So some of our pediatric nurses here were curious in knowing when setting the stage, what you would recommend, or how you think we could describe it to toddlers.
Yeah, so you kind of just, well, a toddler, I'm wondering if my daughter's almost 2, and I'm like, she understands a lot. I'm not sure how much, but the idea of helping them realize they're going to go to maybe to lulla or to dream. We're going to go into a dream. Basically, this medicine we're about to give you is going to bring you into a dream. And I want you to imagine your most beautiful, happy place that brings you peace that you can go to in this dream? What does that look like for you? And then, if they're old enough to be able to talk and converse about it, I had one kid tell me it was the beach for him. And we're like, okay, it's time for you to go to the beach, Johnny. Just imagine you're there on the sand. You're going to put your feet in the waves. You're playing with the sandcat, just like kind of like literally setting the stage, setting the dream for them. And this particular patient had, probably a memorable, but not, traumatic experience. So yeah, it can be as simple as just helping them connect with their happy place, with a really peaceful thought for them or a peaceful place for them. Having a parent nearby, it's important to just let the parent know, like, it's going to look like they're asleep. There might be some interesting eye movements. They might be looking, odd, but know that they're not in pain, that they're going to be, in a very relaxed place. And although it looks strange for you, that they're very safe and they're very comfortable. It's because the parent might also have a little bit of like a reaction, just, being there watching it. If you don't know what you're about to see, might look weird. So yeah, that's what I would suggest. And then, always helping someone connect with their breathing and a mantra. So if a kid can understand, let's take some deep breaths together as we go to the beach, just help them relax. And then, for really deep psychedelic experiences, I can think of my own personal accounts of, no, I'm going to go into a deep space, just reminding myself that my mantra is trust and love, trust and love. And so I'll be repeating that to myself. And I have clients who do the same thing. I'm like, when you're starting to go to that space and you're like, can I let go more? Or am I afraid to let go? Like, you kind of have a decision to make in that space. And so what mantra or what word could you repeat to yourself to allow yourself to relax deeper into the experience? And, a lot of them will say something similar: trust, love, let go, I love you, I am that I am, or I am consciousness, just something that they can help ground with. And then as they lean into that mantra, they end up being able to go deeper and deeper. And these are in the doses of ketamine where you don't really necessarily you still have some sense of control. Whereas, a very, very, very high dose could make you, you're going to go to that space regardless. And there's no holding back. So it's better to just open up into it. And a mantra is very helpful for that. Okay.
Awesome. Thank you.
You're welcome. So just to touch on the research, there's lots of studies published, very interesting. I won't go into too many details other than there's been over 10,000 publications on safety, and we're realizing that ketamine is usually devoid of any life-threatening side effects, even in case reports where there have been accidental extra high, more than we really even wanted to acknowledge we're giving doses, that the patients recovered. And along with that, we're not seeing any long-term impairment of behavior or personality with repeated use. People aren't they're not becoming dumber, for example, or making like compulsive or impulsive decisions. In fact, I would argue that they're growing in their spiritual consciousness and probably becoming better humans. Psychiatric and medical uses, depression, we see this especially in treatment-resistant depression. We're finding ketamine very effective end of anxiety. It's been studied in that, as well as just run-of-the-mill anxiety. We're seeing it as a treatment for PTSD, addiction. There's a lot of studies looking at particularly alcoholism and heroin abuse, as well as for chronic pain. And I should mention, I didn't put it on here, but migraines, case reports and some data is showing that, even one dose can be effective in ending migraines for a substantial amount of time, months, if not totally. Clinical applications, as in anesthetic, we see it used as preoperative sedation, intraoperative anesthesia and sedation, postoperative pain control, even chronic pain control, or patients could be on drips. We have procedural sedation and conscious sedation, like the episodes that were discussed just now with the knee laceration in the ER, or with reduction of fractures, very commonly used. We see it for acute sedation, so the chemical takedown in your ER to get a rowdy psychotic patient under control. Anti-epileptic benefits, both for those patients with the NMDA receptor agonism by teratomas and just in general patients who have epilepsy. Veterinary medicine as an anesthetic and a form of intraoperative anesthesia. And then on the psychiatric note, depression, anxiety, PTSD, addiction, like mentioned before. And in the means of either doing intramuscular, sublingual, intranasal infusions, or fusing that with therapy. So then we call that ketamine-assisted therapy or ketamine-assisted psychotherapy. So you're using ketamine plus having a component of talking. So when does that talking come in? A lot of people don't talk on the ketamine. They're not going to be very verbal at the high doses. And afterwards, a lot of them have trouble kind of putting words together. And some of them are very eloquent. I have a patient who on one dose, let's see, 90 milligrams IM won't say a word. And then another patient on that same dose is kind of talking through the whole thing and describing their profound realizations and even communicating with me, asking questions. So these doses affect people differently due to differences in our metabolism and volume of distribution, our excretion. It's primarily the kidneys. And so we think that probably about 2 to 3 days after the session is a good time for psychotherapy or some type of talk therapy and reflection and opportunity to integrate. In my practice, I do offer that right after the session. I check in with them about how it went for them. And then we make sure that they're going to connect with their therapist, that they have me to reach out to as well, as I can provide extra support. And then I ask them to journal, because a lot of times you're in a really restful state for the rest of the day. You won't be driving, you won't be doing any work or lifting heavy things. It's just a time to rest and reflect. And these experiences are very profound. And a lot of times other people won't necessarily be able to understand them. They can't be verbalized. They're ineffable, as we say in the field. And so it's great to just write down, or my preference is to do an audio journal, because then you can really capture the state of that patient's emotions by the vibrations in the voice and their sound. And you can then tap back into that at a later time if you wanted to remember, hey, I know I am full consciousness. I know I'm not limited to my body. I remember that from my ketamine experience. Let me go back and listen to that to just remind myself what it feels like to be there. So in a way, you can gain benefit from just having that recording. And so I do, with the permission of my patients, record them as they begin to talk. If they talk during the session, we start the recording sooner. But if they want to capture their insights at the very end, or just the vibration and the tone of their voice in this deeply relaxed state, we'll record when they start speaking at the end. Okay, now dosing. As I mentioned, a number of doses. I didn't mention rectal, but it's there on this chart. So you have an analgesic dose, which is the same as the anxiolytic dose. So we're going to be relieving pain and anxiety at these minimum doses. So when we talk about the dosing, just keeping in mind that the IV is more bioavailable than the IM, so you need less of it, and you need more of the other forms because they're not as bioavailable. Pretty comparable across the board between sublingual, oral, and rectal. And then for sedation, we don't utilize sublingual, oral, or rectal. And I will make a note about rectal is if you push it up too high, it's going to go to your portal hepatic circulation. It's going to get metabolized by your liver. So there's this like 1 inch or so that you could apply it inside that would bypass the liver and go straight into the central circulation. And that's probably going to be how you get more effect of the ketamine rather than pushing it up more than that amount and then getting it metabolized a bit by the liver and the kidneys. So then we have the sedation doses, which are quite higher, like 2 to 4 mg per kg IM and a half to a mg per kg IV. And when we say IV, we're talking about a single administration. So you were saying for your anesthesia with that child, they were using like half a mg per kg, I think, IV push. Was that right?
No,
It was 1 to 2.
No, 1 to 2. And I think
1
usually
to 2.
that we'd give like 2 milligrams per kilo one time. And then, like you said, it was kind of predictable as to how long it would last. And then we could repeat another dose if needed.
Yeah. Did you guys have a CO2 monitor on her, an EKG monitor and all that stuff?
Yeah.
At the dose. Yeah.
Yes.
Yeah, for sure.
Mm-hmm.
Yeah. So that would be considered a surgical anesthesia dose because you were performing, it's like a bedside surgery, but still it was a high enough of a dose where that level of monitoring is reasonable. And in the clinics, when we use 100 milligrams or so, usually that's within that range. So we have a 3-lead EKG on them. We don't use a CO2 external monitor. So then what are the induced non-ordinary states of consciousness that we'll see at these doses? Well, there's kind of like 4 major described states. There's an empathogenic state where we have awareness of our body. We feel really relaxed. I've heard clients in this stage say, oh, I'm so grateful for you. I'm so grateful for the experience. They feel warmth and compassion. And these are the lower doses, 25 to 50 milligrams IM. And all of these IM doses are going to be lasting about 45 to 60 minutes. So that's what's on the right hand side. Then you have the out of body experience. So there's that sense of separation, like, ooh, I left my body. Your ego's diminished, your defenses are lowered. You might have, emotional stuff come up for you, and that's considered a medium dose, 75 to 125. In that range, though, I have to say I've had patients get a dose less than this 150 milligram IM dose and still have a near death departure, where they're completely lost their identity, their ego is dissolved, they've left their body, they don't know who they are, they don't know where they are. And then the extreme form of that is the ego dissolving transcendental experience. So the difference here is that there's a state of ecstasy, there's a state of maybe they met their maker, maybe there's white light, maybe there's some greater emotional attachment to that separation. And so you've really lost the boundaries between yourself and your external reality. And we see that that's rare in low doses. So something like 50 to, the nasal dose that you're getting with S-ketamine is not going to be high enough to be giving this experience. And it'll be somewhere between 150 and 200 milligrams IM or so. I had a client, I think got like 120 IM and was like, just this interesting observer of the scene on the beach and didn't quite even get to that necessarily a transcendental, like ecstatic state. But, so again, dose dependency. And that was a little less in this 150 to 200. I typically think if you are looking for that kind of depth of experience, it can be a little more wise or safe at this time to do that by an IV drip in the event that the blood pressure goes high. In some clinical cases, or my colleagues, they'll see pressures go to the 190s over 100s, low 100s. It could be because of the psychological nature of the experience, or it could be that that there's a physiologic response that's causing that blood pressure increase. And in those cases, then you could administer some anti-hypertensive, or you could stop the drip. So, but yes, it's been well documented that doses, like I said, my ER staff gave a patient 300 milligrams IM just to get them sedated. So, 150 to 200 isn't unreasonable to do by IM, assuming that the patient's prepared for the depth of that experience. The pharmacodynamics, we see elimination primarily by the kidneys. You'll see a small percent of the recovered drug in the urine unchanged, but most of it's metabolites and breakdown products, and those can be present a week or more. And for the various routes, you'll see that the half-lives are all the same, but the peak plasma concentrations are much quicker with the IV and IM. We're looking at 1 and 5 to 15 minutes. But the onset, I have to note, is more like 1 minute for IV and 3 to 4 minutes for IM. So this is just talking about the peak concentration. So in Salvador Roque's work, he would give 3 injections of these high doses of around 120 or 150, and he would do 3 of them. And you could do them at the 15-minute mark. So when the patient has a peak plasma concentration, or even 5 or 10 minutes in, you're giving another dose so they can stay at the peak plasma concentration. So technically, if you wanted to keep an experience prolonged at the IM route, you could give 1 dose, 10 minutes later, give the second dose, 10 minutes later, give a third dose. And I think that was kind of what he was doing in his practice. With the oral sublingual troches, as we call them, about 30 minutes to onset and does last a number of hours. Some clients I have say like for the rest of the evening until they went to bed. So maybe like 3-4 hours of effect where they were notably different. And then rectal, about 45 minutes to reach plasma peak concentration with a similar length of time of effect as oral. Okay, so I know we're a little bit over time. It looks like it's 4:05 my time on the East Coast here. But I just wanted to make a note about patient anecdotal experiences. It's just so fascinating what people will describe. I've heard things like, oh gosh, comments about God is a ball, God is warmth, I am the warmth, I am consciousness, I am expanded. But there'll be feelings of complete departure from the body, a loss of identity. Some people will think that they have died, but being really aware of their words, like speaking slowly and noticing the vibrations of their words, going to mystical realms. Some patients have very vivid colors that they see. Maybe like a feeling of rebirth. Some of the neatest comments I've heard are, I felt like my brain was being surgerized. I was having these maladaptive connections being cut out, or it felt very like it felt like very healing for my brain. I've had multiple patients say that their brain felt like it was healing in that space, and that they had a lot of healing happen in that space. And I love thinking about it as okay, if they're going into a theta space, so much is possible from the standpoint of like modifying the brain's processes and rewiring these connections to be conducive. In that state, you're not connecting with the pain in your body. You can rewire pathways that are free from pain. In that state, there's a lot of malleability. I have one patient who's also a musician, and they are particularly exploring this as a way to make their life more malleable. And he's noted that it's improved his musicality, and will most definitely have better performances, faster fingers, more cohesive state of being. I have another client who noticed just every little sound, the importance of every sound, both as they were coming out of the experience and in the experience. And so in my practice, we're using eye shades are optional, because we do project some lovely images on the ceiling and in the wall in front of you, but the headphones are usually what's preferred to the music in the room, just because of the depth of the importance of the music. And so I know Mark talked a lot about this last week when he was talking about more the philosophy of going into these experiences, preparing patients, holding the space, and then integrating with them. But the music aspect, especially with ketamine, we definitely advise for lyricless music that's of a relaxing nature. And I have a number of playlists I've created for clients. Of course, they're allowed to bring their own music as long as it kind of fits that bill of being lyricless and expansive for them as a relaxing form of musical medication. So we just really like to kind of create as much of that experience tailored for them, and that they don't have to think about it. They can just show up. We have the little iPod for them, the headphones, the option to play the music in the room in addition, and just kind of like a really very comfortable recliner and a way for them to relax into it. So yeah, I think the experiences have been really wholly positive. I think I feel really blessed to get to work with this modality, and for its status as an inexpensive, legal, and widely available form of treatment. I think personally, I feel like I for everyone who qualifies for the treatment, that I don't feel right withholding it from anyone for financial reasons. So even though I don't accept insurance, I provide scholarship for patients. I provide sliding scale experiences. And what I think is really great about that is that we can provide group sessions with a modality like this, so that there can be group connection. I really like that aspect of Salvador Roque's work, is that these patients were coming together and helping each other integrate and holding space for one another. And that's going to be a lasting and additive benefit to the experience, as these individuals will have an opportunity to connect with other people who are similarly exploring this space. And so just that added connection, I think, is really helpful. So yeah, I really feel really grateful to get an opportunity to share this with y'all. This is one of my deep joys and passions, and I'm very excited to share these references with you. I used the Ketamine Papers, Science, Therapy, and Transformation text by MAPS. If you can see my video here on the screen, this is what the book looks like. I'm not 100% sure it's still available on the MAPS website. I went to try and buy another copy like a couple months ago, and it wasn't available. But maybe if you're really interested, it could be, we could reach out to MAPS and ask them to publish more of them, because I don't find this copy on Amazon. I haven't found this book anywhere but on the MAPS website, because they are the publishers. But it's really fascinating. I highly recommend it if you're interested. I had a patient read it from cover to cover before deciding to start her therapy, and she gave it to her therapist to read as well. And so I just think it's very informative, and it does touch on a lot of what we discussed and then some. And of course, I just put arrowwood.org there as a great reference or resource for anybody who's curious about any real type of psychedelic or medication that's not really commonly used, or if you want more case reports or just personal accounts and know more about the chemistry. Arrowwood's just a great resource all around. So thank you all so much.